Hello friends, welcome back to the second part of medicine recall. So a patient with dental caries is going to undergo tooth extraction. In which of the following conditions prophylaxis for infective endocarditis is not recommended? A. Uncorrected cyanotic heart disease, B. ASD, C. Mechanical valve, D is previous history of infective endocarditis. So when do you give prophylaxis for infective endocarditis? Only when there is a high risk patient with a high risk procedure. Only when both are there, then you should consider prophylaxis. Okay, high risk patient means some 4 categories you should be remembering. First is the patient a history of previous infective endocarditis. If one more attack comes, it will be very severe and it might lead to complications. Next is prosthetic valves. They need prophylaxis. Next is congenital heart disease. If you see, if it is cyanotic, then if it is uncorrected or partially corrected, they need prophylaxis. Okay, and usually acyanotic heart disease doesn't need prophylaxis. Only even if it is in ASD, after patch closure during 6 months they will be needing prophylaxis, but after that they won't be needing prophylaxis. Any history of cardiac transplant, all these things are the high risk patients. Now we will see high risk procedures. High risk procedures means anything, any dental work involving manipulation of the gingival tissue or periapical portion of the tooth, okay, or any perforation of oral mucosa. All are high risk procedures. So what to give in this? Ampicillin 2 grams, ampicillin 2 grams, or azithromycin, clarithromycin 500 mg, or you can give clindamycin 600 mg. Everything half an hour before the procedure, only a stat dose. The most fitting option will be ASD. Next, a patient with altered consciousness, irregular pulse and pulse deficit of more than 20, and what can be found in his JVP. So irregular pulse with pulse deficit more than 20, more than 10 means it is nothing but atrial fibrillation. In atrial fibrillation, all multiple parts of the atrium trying to contract, but effective contraction is not happening. If effective atrial systole is not happening, the A wave, atrial kick doesn't happen. So A waves will be absent in JVP. Which of the following is the drug of choice for treatment of acute migraine? They are given features of phonophobia, photophobia and autonomic features. So A. propranolol, sumatriptan, flunarizine, topiramate. Obviously answer will be sumatriptan. See, migraine acute attacks, the treatment of choice drugs will be, first you will be giving NSAIDs, next you will be giving triptans. Triptans mechanism of action is they will stimulate 5-HT1B1D, which has vasoconstrictive action. It can cause coronary vasospasms, cerebral vasospasms. So only these triptans are contraindicated in patients having CAD as well as CVA patients. And also it stimulates 5-HT1D, which inhibits the release of the CGRP and the neuroinflammation is reduced. Okay, so this is the main action. So what we did recently is we have introduced the recent drug called Ditens, lasmiditan, which has only this property of 5-HT1D agonism. It doesn't have this 5-HT1B1D agonism. So it is safe even in CAD CVA patients. Lasmiditan. So options obviously sumatriptan will be the answer. And other 3, propranolol, topiramate and flunarizine, all are given for only for prophylaxis of migraine, not for treatment. Patient presents with fatigability, ECG shows depressed ST, short T wave and U wave is present. What is the diagnosis? Hypernatremia, hyponatremia, hyperkalemia, hypokalemia. So what is happening here? Patient is having fatigability along with these changes. So usually if you see this action potential, this is the cardiac action potential. In the phase 2, 3 and 4, what is happening? Potassium is going out of the cell. K plus F-flex is happening. So if you see, according to this, I have drawn the ECG curve. So in this curve, if you see the phase 4 part where the potassium is effluxing, only potassium is effluxing out in the last phase, which contributes to the repolarization phase and which contributes to the T wave. So what happens in hypokalemia is outside the cell, potassium is very low. So from the cell, myocardial cell, potassium from inside the cell, it will be pouring out continuously. It will be going out continuously since outside the potassium is very low. So this K plus efflux will be prolonged to that extent that this T wave will be split into two. A small initial T wave and followed by a large U wave. Okay, so this is called U wave. So if you find this short T wave and a large U wave, it is nothing but hypokalemia, and patient has fatigability because of this hypokalemia and muscle weakness. 68-year-old diabetic patient with history of COVID infection 4 months back presents with loosening of teeth. What is appropriate action? HbA1c, serum ferritin, nasal swab for mucor. They are just telling history of post-COVID diabetic patient hai plus loosening of tooth because of sinus involvement, maxillary sinus involvement, nothing but mucormycosis. So we will be taking nasal swab for mucor. The marker of B2, vitamin B2 status in RBCs, nothing but glutathione peroxidase. Transketolase is for vitamin B1. Okay. Next, a known case of diabetes, type 1 diabetes, random blood glucose 588, urine for ketones was positive, and patient was having altered sensorium. So in this patient, what is the treatment? IV fluids alone or IV fluids with regular insulin infusion, IV fluids with long-acting insulin. Nothing but first for diabetic, this nothing but diabetic ketoacidosis, which is given in the question. In DKA, first treatment should be to wash off the ketones. We'll be giving lots of fluids along with insulin infusion, which is nothing but the regular insulin which is used. And 3 questions were asked for toxicity and drug of choice. One is paracetamol toxicity, drug of choice is N-acetylcysteine. And digoxin toxicity, drug of choice digibind. And one more question, opium toxicity with patient having altered consciousness, comatose state and respiratory distress. Obviously answer will be IV naloxone. Naltrexone is for maintenance, chronic therapy, long acting. Okay, it will be used for maintenance to prevent withdrawal. Acute settings, drug of choice will be IV naloxone. Then this question, a woman on antidepressants and the ECG is having wide QRS complexes and patient is in hypotension and altered sensorium. So for this patient, what is the drug of choice? A. Physostigmine, B. DC cardioversion, C. IV soda bicarb, and Panlon. So nothing but it is TCA toxicity, tricyclic antidepressants. TCA inhibits lots of receptors. One is peripheral alpha-1 adrenergic receptor, which is responsible for vasoconstriction. So this won't be happening at all due to toxicity, causing vasodilation, and this results in refractory hypotension. Next is inhibition of this muscarinic receptor. So if this muscarinic receptor is inhibited in the heart, it will cause tachycardia. And this cholinergic receptors, if it is inhibited in the brain, that will lead to delirium, altered sensorium, seizures, all these are possible. And also in heart, what happens is slowly the patient will be developing features of widening of QRS, and slowly patient will develop VT or VFib, ventricular fibrillation. Pupils, if you see, since it is anticholinergic, pupils will be dilated, anticholinergic, so urinary retention might also be seen and hyperthermia might also be seen. So treatment of choice is nothing but soda bicarb. To prevent this cardiac toxicity, we are giving this soda bicarb for this patient. Next, a person taking ATD for a long time develops paresthesia or burning pain over bilateral lower limb. What is it due to deficiency of dash vitamin? B6, B12, B3. What is the vitamin? It's nothing but B6. Due to isoniazid component in ATD, this can cause B6 deficiency, due to which patient can develop peripheral neuropathy, that to painful peripheral neuropathy. So to prevent this complication only, we supplement ATD with pyridoxine, which is 20 to 40 mg OD. But if the patient has developed peripheral neuropathy, then we will give pyridoxine of 100 mg OD. A child having HLA-DQ2 positivity and on duodenal biopsy shows script hyperplasia villus atrophy, and in this patient, what diet you are going to prescribe? lactose free diet or gluten free diet. So HLA-DQ2 nothing but it indicates celiac disease. Along with this, biopsy findings also indicates celiac disease. So in this patient, you will be obviously prescribing gluten free diet. How to diagnose MDR-TB? Resistance to isoniazid and rifampicin, resistance to H plus R plus kanamycin, resistance to H plus R plus leoflox. So here, let's see all the resistance pattern in tuberculosis. First is if it is first line drugs HRZD. If it is resistant to any one of the first line drug, then we call it as mono drug resistant tuberculosis. If it is resistant to H plus Z or E without involving R, then it is called polydrug resistant tuberculosis. If H plus R with or without any first line drug resistance is there, then we call it as MDR-TB. Okay, if this combination associated with some fluoroquinolone resistance, then we call it as pre-XDR-TB. And if this combo along with bedaquiline or linezolid or moxifloxacin resistance is there, then that is the XDR-TB. Okay. Yes. So the answer to this question will be MDR cox is nothing but H plus R resistance. That's it. Thanks for watching. We'll be coming with follow-up video soon. Thank you.